I'm Max Feinstein. I'm a pediatric anesthesiologist at the Mount Sinai Hospital, and these are my essentials. If you're a healthcare professional, especially if you're in anesthesiology, you may see a couple of items on here that might be controversial, namely this video laryngoscope and this ultrasound. But we'll get to that. The first item, however, is only controversial if it is not an essential item for an anesthesiologist. And that, of course, is a stethoscope, which can be used, among other things, to listen to a patient's heart and lungs. You'll notice that this is a pediatric stethoscope, which facilitates listening to very small patients. I use a stethoscope before we go back to the operating room so that I can listen to the heart and lungs and see if there's anything abnormal about the way that their heart sounds or their lungs. And then once I'm in the operating room, if there's any problem at all with the patient's breathing, then I use this device to help me figure out what might or might not be going on. And yes, that means that during a surgery, while the patient's under the drapes, I would put the stethoscope on and then actually listen to the patient's lungs and see if there's a sound that's unusual or an absence of sounds that would point me towards a problem that might be going on. Another piece of monitoring equipment that I find to be essential is this portable pulse oximeter, which is a very straightforward piece of equipment. It just slips onto a patient's finger and then will bring up their oxygen saturation, where the maximum is 100%, and the patient's heart rate. These are particularly useful if I'm traveling between an anesthetizing location, like the operating room, and the recovery room, and I don't have all of my monitoring equipment with me. I can just put this on a patient's finger and right away I'll be able to get their oxygen saturation and their pulse by just looking at the device. Having pointed this out, if I'm really concerned about a patient's vital signs and needed to monitor them even more closely during the transport process, then I would bring a full transport monitor with me where I could get the oxygen saturation, the heart rate, the blood pressure, and a number of other parameters that I might want to see. Moving along to equipment related to a patient's airway, this device might be controversial for some anesthesiologists, and this is a video laryngoscope. So as you can see, there's a screen that displays what is on the camera right here, and this can be used to intubate patients. This particular device, which is called a McGrath, has different blades that can fit on here for different size patients. And their smallest blade that they have available, called a MAC 1, I have been able to use for patients as small as 2.5 kilograms. So I carry this with me as a backup in the event that there's an issue using direct laryngoscopy, which is intubating without video. This might be able to provide some visualization that I'm not getting with a direct laryngoscope. This is the smallest blade that McGrath makes, which, as I said, is the MAC 1. And it looks like this, and fits on the scope just like that. My next essential is also related to the airway, and that is ICU tape. If you know anything about anesthesiologists, you may know that pediatric anesthesiologists have a reputation for being, let's just say, nitpicky about anything related to adhesives, and I am no different. So this particular type of tape is very strong, and that's important to me to make sure that when I tape an endotracheal tube in place, that it is not going to come out. I obviously don't want a tube to come out if we're talking about an adult patient, but the likelihood of having a problem with a very small patient is probably a bit higher because there's just smaller margin of error. So if I pull an endotracheal tube back 1 centimeter for an adult patient, that's probably not going to have any sort of meaningful impact on my ability to deliver oxygen to their lungs. But if I pull the tube back 1 centimeter on a 3-kilo baby, that might mean the difference between being intubated and being extubated. So it's important that my endotracheal tube doesn't go anywhere. And if you've ever used this type of tape before, you know that it's not really possible to tear it very easily. So it's also important to make sure that you've got a pair of scissors around to be able to cut it. And I will say that another part of the reputation pediatric anesthesiologists have is with arts and crafts, because we get very particular about the way that we cut our tape, and I won't get into it in this video, but it's a thing. Next up is equipment related to getting vascular access. And as I pointed out, ultrasounds have the potential for being a bit controversial in anesthesiology. Basically, the two different philosophies that are out there on the opposite ends of the spectrum are that either on the one hand, you as the anesthesiologist should be able to place any line, arterial line, central line, peripheral IV, without an ultrasound, and if you resort to an ultrasound, you're probably demonstrating that you don't have that ability. So that's one extreme. The other extreme is everyone should always use ultrasound as the very first attempt for placing any line, whether we're talking about an IV or a central line or an arterial line. And I tend to fall pretty close to that category, particularly when we're talking about pediatric patients. It's one thing if we're talking about a patient who's got veins popping out of everywhere, and if you threw a needle at them from across the room, it would land in a vein. I mean, sure, of course we're not going to use an ultrasound for a patient like that. But if you're taking care of a young patient, then there's a reasonably high chance that you're not going to place an IV in that patient before they go under anesthesia, because that can be very traumatic for young patients. So in many cases in pediatric anesthesiology, we'll administer anesthesia that's breathed in through a mask, have the patient go under anesthesia, and then we place an IV. And in that situation, time is really of the essence because most of the medications that we administer are administered through an IV. So we need to establish IV access quickly. Now, if there's a vein that's visible, then that's probably going to be the fastest way to establish IV access in a pediatric patient. But if there aren't veins that are easily visible or palpated, meaning feeling them with my finger even though I can't see them, then I have a very low threshold to just grab the ultrasound and see if I can find something that's not visible to my eye. I do admit that it can be a little cumbersome to get the ultrasound, turn it on, apply the jelly to be able to actually get an image when you put the probe on the patient's skin. It can end up saving you a lot of time if the patient is a moderately difficult stick, meaning it is a bit challenging to get IV access for them. And so I think it's much better to just go for an ultrasound if you're not going to be able to get an IV right away. And then that way you can save yourself the time of having to sit there and just poke the patient at one spot and another spot and another spot. Also, if you're not using an ultrasound and you attempt to place an IV but it blows a vein, then you have one fewer option for where you can place it because that vein is now blown. I think that's an especially important consideration when we're talking about arterial lines, because now you're talking about putting a needle into a high pressure artery. And so if you poke extra holes through that artery, you're going to have blood that leaks outside of the artery, causes a hematoma, even getting to the point of limiting blood flow to wherever that artery is going. For example, the hand, because oftentimes arterial lines are placed in the radial artery. Given the risk of vascular injury when we're placing arterial lines or central lines, meaning IVs that go directly to the heart, so oftentimes placed in the neck or sometimes in other places, in these circumstances, I think the use of an ultrasound is just better for patient safety. And ultimately, my litmus test is if I were a parent of a child who's having surgery, what would I want my anesthesiologist to do? Anyways, some people have very strong opinions about this on both ends of the spectrum, so I'll be very interested to read what the comment section looks like after I post this video. Next up, and also related to IVs, are these insulin needles that I use very frequently to reduce the pain associated with having an IV placed while a patient is awake. So this is a 31 gauge insulin needle that's so small that you can only barely see it here. And what I use this for is drawing up lidocaine and also buffering that with bicarbonate. Lidocaine itself can numb an area, but ironically, it actually hurts a little bit when lidocaine gets injected. And the way that we can make it hurt less or not at all is to buffer it with bicarb, meaning mixing it together. And I'll use this to inject about 1/2 milliliter of my combination of lidocaine and bicarb into the area where I then place my needle. Patients routinely tell me that they feel nothing when I use this to place the lidocaine and bicarb, and then also feel nothing when I go ahead and place the IV. Perhaps surprisingly, the use of a numbing agent like this or others can also be somewhat controversial because there are some healthcare professionals who believe that if a patient is coming to the hospital and going to have surgery, then there are going to be things that are uncomfortable and they should just deal with it. Now, to be fair, having a 22 gauge IV placed probably isn't going to be particularly uncomfortable, and so I can see how that's reasonable. But if it's going to be much larger of an IV, or it's going to be in a sensitive area like the hand, and it's easy to have access to a device like this, I feel like why not make the patient more comfortable? This is especially important for me in pediatric anesthesiology, where I'm routinely taking care of patients who come to the hospital for the first time at a very young age to get a surgery done, and then have to keep coming back either for routine follow-up or more surgeries in the future. I want to make sure that this patient's early experiences with an anesthesiologist and healthcare professionals in general is as pleasant as possible, because it's actually possible for patients of any age, and especially young patients, to develop PTSD from medical experiences. So anything that I can do to minimize trauma, whether it's psychological or physical, while the patient is in the hospital, is worth doing. There are a number of other devices and methods for reducing pain associated with IV placement. I just prefer using this technique because it's fast, it's versatile, and it's very effective. The other essential equipment that I use that's also related to IV placement is this special dressing here. Now, there are a variety of different dressings available for IVs, but this is the one that is used by ICUs most frequently because it's very sticky and isn't going to fail as readily as other devices that aren't quite as adhesive. An alternative adhesive is this Tegaderm that is used very frequently and is fine in a lot of circumstances, but just isn't quite as sticky. So if a patient's coming in for a quick ambulatory surgery and they just have one IV placed and this Tegaderm goes over the IV, then it'll probably work for the case. And when everything's all done, this just comes off and the patient can head home. But if you're placing an IV that you need to be certain stays in during surgery and for some period of time afterwards, then it might be wise to use something stronger, which is why I like this particular adhesive that has some structure to it. And most importantly, even though it can be uncomfortable when it comes off because it's a little bit stronger, the fact of it being stronger does, I think, make this a safer device when being used for longer surgeries, for pediatric patients, or patients who are going to be in the hospital for some period of time after the surgery. Of course, anesthesiologists rely on numerous medications to be able to safely take care of patients, but for the sake of brevity, I picked out just one medication that I consider my most essential, and that is epinephrine. Epinephrine is a vasopressor that is helpful not just for managing blood pressure, but also very helpful for managing anaphylaxis or a lung condition called bronchospasm, which can be part of the clinical picture of anaphylaxis. Along with chest compressions, epinephrine is the foundation of the advanced cardiovascular life support algorithm, so I think this is a great drug to have on me at all times, which I do. So I carry this syringe around in the hospital, and this is diluted down to 10 micrograms per milliliter, making it a versatile concentration to be able to use in both adults and pediatrics. And this can be administered either through the IV, through an intramuscular needle, so I don't need to have IV access, or in the case of bronchospasm, this can even be administered through an endotracheal tube. Rounding out the list are a couple of miscellaneous items that might not be life-saving, but are definitely essential in my book. One of those is having a Sharpie. So it's often the case that I'm labeling medications, or since I work in a teaching hospital and I enjoy diagramming things and explaining concepts to trainees, then I like to have something that I can write with, and a Sharpie, of course, writes on everything. Last but certainly not least on the essential list is having a fun scrub cap, which not only is socially acceptable as a pediatric anesthesiologist, but allows me to have fun little inside anesthesiology jokes that aren't really that funny but make me smile. So the goose, for example, is a reminder to not put the endotracheal tube in the esophagus. And the scrub cap that I'm wearing now, they might be llamas, but I call them alpacas. And I wear these alpacas anytime I take care of a patient with a condition called alcapa, which stands for anomalous left coronary artery coming off the pulmonary artery, just because I like the alliteration of my alcapa alpacas. If you enjoyed this video, you might want to check out this video I made where I show what it's like to use epinephrine when a patient is having a problem in an operating room. Thanks very much for watching. I'll see you next time.